Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner back with The Lionhearted. I want to start out today by just kind of reminding you what these podcasts are from my point of view. In case you haven't noticed, I don't have any guests. Not yet. I haven't decided how I'm going to do that or whether... There are some guests I'm going to have. Key people that work for me, like Michelle, who's been my new patient coordinator and my financial coordinator for the last 39 years. I think it is important to hear from her. But I got to be honest with you, it's daunting to do these every week in the sense that you will find out, if depending where you're at in life right now, that you always stop and think about what is the end goal with something new that you will tackle. And you must know by now that I do not think that I have the only answer. I have my answer, my voice. And so I'm hoping these are conversational for you. And that I'm just a person who has had a pretty good track record in the same profession you're in. And it's hard for me to decide each week exactly where I should go. Because as I see it, there's somewhere around 300 of you downloading these each week. And you're at all different levels. Some of you are in dental school right now, and God almighty, do I give you credit? This is the last thing I would do when I was in dental school almost, not almost, 40 years ago. And the fact that you're listening to a guy my age and is flattering, quite honestly. And I do have a lot of you following me from there. And I have many of you outside the United States. And I don't know whether everything I say resonates in the part of the world you're in. But as I said from the very beginning, and I don't know which podcast this is for me right now that you're on, but I know we're close to 20. And my hat's off, by the way, to the Gary Takises of the world and Peter Boland, if I'm saying that right, and Justin Moody's and guys that have been doing this for years and years. I don't know where it'll go. As long as I think I'm resonating to some of you or enough of you, I guess I'll keep going on. And I'm not saying that for you to write to me and say, oh, please keep doing it. I guess this is what I'm saying. I'm a very conversational kind of guy. When I decided to do these initially, I thought it would be a cool way to communicate with a lot of you because so many of you reach out to me when I've done other well-known podcasts. And it just seemed like a natural. But it is pretty hard. It's hard to come up with being worthy stuff, to be honest with you. I mean, right now, I don't know when you're listening to this. It could be somebody dropping your kids off and you're going to the gym. Or maybe you're on the way to work. Or maybe you're on the way to class and you are in dental school. Or maybe you're a brand new dentist at the end of your rope. Or killing it. Maybe you've implemented. I've had some of you write to me, and one of you said you got a tremendous, huge treatment plan, and you said that was the first time that had happened. And it doesn't surprise me. I mean, I'm sharing with you what I've done for many, many years. And of course it works. I'm not up. Why else would I do this? I'm hoping some of you show up at courses that I take. I mean, that I give. And you go to my schedule at the Rasner Institute and look where I'm giving courses in the next 12 to 24 months. Or take my own course in my office that I give for atraumatic extractions, implant site development, which is bone grafting, and of course implants themselves. And so, I'm a voice. I guess I'm saying this for myself as well tonight. And you can reach me, as you know, at my name. Maybe one day I will join you and I'll laugh at the fact that I am still Dr. Rasner at AOL.com. Dr. No period, my last name, Rasner at AOL.com. But anyway, I continue to do these, and in the last couple, I've been talking about developing a large nucleus of a practice. And I thought about that before I came on tonight, because it may sound contradictory for me, especially to say that, because I come on over these podcasts and I've talked about you having a thriving fee-for-service practice, not this giant conglomerate. But it really isn't a contradiction. You know why? Because the nucleus that I speak of, this big practice base that I want you to develop, is not ever 100% active. Parts of it remain dormant, and sometimes part of it will fall off and be quiet, and other times it's all clicking on all cylinders. And look, I want you to have what I've had. And for many years, to be quite honest with you, it has been on automatic pilot. To have 29 consecutive years, as I once had, and of increased growth and net profit, means something's working. And I assure you, I wasn't reinventing the wheel every year. I always would brush up on things or change my strategies. I'm very, very in tune when I think something may be getting stale. So I want you to have and spend your early years, or maybe even in your mid-years right now, regaining the nucleus, and when I say that, of course, I mean the base practice size to be fairly large, because it protects you. And what I mean by that is everybody in that nucleus may not be active, but they embrace a common denominator of trust. They trust you. And that's the thing we got to get back to, and I got to clarify for you in these next couple podcasts, because not everybody's going to sign on for what you want them to do or what you're recommending. Of course they're not going to do that. And I'm going to try to help you figure out what to do with these patients that aren't signing on to do exactly the treatment plan you recommended, or maybe nothing that even closely resembles the treatment plan you recommended. So let me start this tonight by talking about something I talked about in the early podcast, but I don't think you can get enough of it. And that is, what is it I'm doing in those early moments when I'm talking to the patient for the first time? And I'm not going to go into quite the detail I went into, because I went over that over 4 or 5 different podcasts. But I need to refresh you, or help those of you that have come into my podcast late to hear what I'm talking about. So what we're going to be talking about right now, again, is what happens when I'm in front of a new patient, and then what happens if they don't accept the treatment I recommended, which is very, very often. I'm not saying they don't accept any treatment. I'm saying they may not accept the treatment I recommend. So what do we do then? Because sometimes they don't accept anything. Sometimes they accept a small portion of it, and then they fall in to that core base that I call a nucleus, and it is enlarged, and they still trust you, even though they didn't go for plan type A premier recommended treatment. So that's what I want to get to at some time in this podcast, or the next one included as well, because I'm sure I won't get it all. So taking you back, I want you to remember some things about my blueprint for success. Case acceptance for me starts at that very first phone call. When they've called your office for the first time, Everybody listening right now, I don't have to convince you. Nobody calls up and says, I want a comprehensive treatment plan. No one does that. And so, in fact, the statistics on the number of offices giving comprehensive treatment plan approaches by the dentist fell miserably up until 2014 or 15. It fell at an accelerated rate. I don't know why it did, which I think is good because it puts me in a more unique position. First of all, I don't want you to comprehensively treatment plan people because it'll make you rich or because it's the right thing to do. There's nothing else to say. All of us listening right now have come across or will come across that tooth, that lower molar, maybe a second molar, and the first molar is missing. So the second molar has drifted mesally and has tilted at a 45-degree angle or greater. And we've all seen that tooth root canal and crowned with no tooth in front of it. Now, I have to tell you, to me, that may be the poster child picture of myopic one-tooth dentistry, meaning very often I believe that dentist went in and treated the symptom. So somebody came into their tooth with a second lower molar that was hot, that needed root canal, and they crowned it. And I just find it hard to believe that the circumstances would be just so exact for me that I would follow such a treatment plan. To me, that's one-tooth dentistry at its worst, by the way. So I don't know how you can possibly bring in a new patient who has a symptom and treat the symptom intelligently without looking at their entire mouth. So naturally, that has to begin at that first phone call. And at that first phone call, we very strategically, and rightfully, by the way, tell this new patient, maybe this new patient on the telephone just wants their tooth yanked. I mean, I'm sure that's the case sometimes. Well, that's not what they're going to be told if they call my office with a symptom. They're going to be told in a very professional and patient-friendly way, by the way. You know, you have to have somebody on that phone, on manning that part of your office, for goodness sakes, that you have total confidence in, that is a people person all the way, that never brings baggage into your office. I would be a bad person. I would be, to have that job in my office, to take new patient phone calls, because I can get in a bad mood and I can't separate it sometimes. I can push it enough away when I go in to see a new patient. But the person in my office that did that job would be just a stellar personality. I mean, somebody at the Four Seasons Hotel or Ritz-Carlton Hotel at their front desk that they are trained not to have a bad mood. And that I cannot underscore that. So when I hear my Michelle, who is on the phone with a new patient, I swear when I'm walking past her desk, I can't tell whether the person she's spoken to is somebody she's known for 25 years or a brand new patient. She has that talent. And while she's bonding and inputting all that information, the next thing that happens at some point during that phone call, of course, is her doing what I used to call a mini dental history. And really, you can call it anything you want. It's a series of 3 to 5 questions that are going to give her a clue, a better clue as to the mouth we're about to meet later that week or the next week. And the questions are pretty obvious. You know, I want to know, when was the last time you were at the dentist? So it's not a inquiry like they're being questioned by the FBI. It's, hey, let me get to know you a little bit better. I want to ask you a couple questions. So when was the last time you went to the dentist? Okay, and that has a big impact on my approach and my preparation. You know, I haven't been in 8 years. Oh my God, I'm so embarrassed. Or I go you're going to love my mouth. Tell Doc he's going to love my mouth. I've been trying to get in there for years. I made the change with this phone call today, but I go to the dentist every 4 months. I've been told I have better hygiene than most of the employees. Well, fine. If that's what it is, I need to know that. She'll go on to ask, which is almost never the case, by the way. She will go on to ask questions like, well, do you wear anything in your mouth that's removable? Do you have any missing teeth? I know you just told me about a specific area in your mouth in the lower right. Is there anything else you can think of? Just that was bothering you before, but maybe that's not bothering you now. That is the atmosphere, my audience, I want you to hear. That's what's going on. Do you have any fears? And if they do really have fears, you won't have to ask them. Okay, so that's what's happening initially. I've also told you, and I have to bring you back to this, to bring you around back into my office when I walk in, to know how powerful that is, and how, if I'm ever going to get case acceptance, I've got everything in play to help me make that happen from that first phone call. If you're not doing what I'm talking about, and if you're not writing to me, if you don't get it, I don't know. I don't know what to tell you. I mean, this is as core value of a successful dental practice as I can share with you. Because then she's going to go further. And by the way, and she's going to say something like this. She's going to say, let me tell you how the first visit is going to work. She literally says, let me tell you how the first visit is going to work. Dr. Rasner is going to take a look at all your teeth, your whole mouth. And usually that is never a problem. But if it was, the follow-up to that would be, listen, I've been with the doctor a long time. And this I know is absolutely true. You will save money and time on whatever decisions you make if he examines your whole mouth. It's impossible for him, according to his philosophy, to give you really good advice on one tooth if he doesn't see the rest of your mouth and how that fits into this picture. So to be clear, if that patient did say, and I can't remember the last time this happened, but if they did say, well, I don't want all that, I just want this one tooth fixed, I'm sure there's people in the profession that would tell you, bring them in, do what they want you to do, bond with them, and bring them back. And I'm here to tell you that that will create a practice of emergencies, and that is not what I would advocate. In other words, if they're not even going to let me do a full exam to decide what to do, even if it is one tooth, then I'm out. I'm not doing it. I'm serious. That's how I feel. Now, the days of when a patient comes in to me and they're totally swollen and they're acutely ill and in pain, I don't get patients like that. And I think that's a function, I did earlier in my career, but I think that's a function of what this thing I've been telling you that we're doing right now is called a screen. And I don't think my bar is very high, to be honest with you. Not to me, it's not. So if they're not even going to let me do a full exam to figure, I'm not asking them to let me mount models on every patient that comes in and centric relation equals centric occlusion. I'm not even asking that. I'm asking to let me examine you in the way I'm about to revisit with you as I have in earlier podcast. The second thing that my new patient coordinator is going to say is Dr. Rasner is also going to take whatever necessary x-rays or other diagnostic tools he may want to use to help make a decision. And when you say that, I say this in my lectures because it's kind of funny, but a lot of patients will say, oh, I had all those x-rays taken just 6 months ago, which usually means they had bite wings taken in the last 8 years. It remains profound to me, the number of patients that visit other offices that qualify to have radiographs done because they haven't been done according to their insurance. So, this is the battle that a lot of us are fighting, because you want to be a good dentist and you want to be comprehensive, and yet the patient very often in your chair has never had this approach. So it can make you look aggressive. We're going to talk about lines drawn in the sand before this subject content that I'm dealing with right now on who you're going to keep in your nucleus and who you're not. Well, some people never make it to my nucleus. There's no way I'm bringing somebody into my office and taking one periapical and treating that tooth. I mean, it's just ridiculous for me to even talk about that to me. And so that's where I draw my line in the sand to begin with. That being said, I will tell you this. If the patient's making a big deal about the radiographs, I would never encourage you to market free stuff to get patients into your office. I would never make the proclamation that the month of May will be discount month for free consultation, free x-rays, free bleaching. I think, and I know I stand alone on a lot of these tenets I'm giving you, but I think free is the worst word you can use in dental marketing, because it actually will attract certain patients to your office. They're just not the right patients. And so that's the line I draw. Either they're going to let me do an exam, and they're going to let me do whatever necessary x-rays I need, or they're not coming in. So that, again, I said at the beginning of this podcast, I've said at the beginning of many, I'm one man's opinion, and that opinion's worked well for me in that particular part of my practice for years. Okay, then they come in. So I don't ever waste time with a hygienist coming to me saying, Doc, I went back to meet the new patient. They don't want me to take any x-rays. Doc, they don't want the exam and everything else. They just want a tooth yanked. That never happens to me because of what I just told you. That's the absolute truth. Okay, next. So when I walk into the room, they've been charted. A very key point I left out. They've had a second in-office interview besides the one on the phone. And I know some of you can get this from earlier podcasts. I don't think you can get enough of what I'm telling you. Even when I'm telling you right now, and I did it today, I'm thinking of things that sometimes I change or forget to include. So they get to the office, and Michelle does another interview. And the reason she does that is, for some reason, I think I do know the reason now, people won't tell you the truth over the telephone. And I think it's because it's their way of not fully committing to the process. Like, in their mind, it's kind of denial. Like, if I don't tell him all these things on the telephone, maybe he won't discover them when I meet him, and I can keep everything minimal. I want it to be minimal too, if that's what they need. You should want it to be minimal as well. But it is what it is if you go through the exam. So I walk in, I do the exam, and remember, the reason I'm going over this again, the reason I'm telling you this today, is because we got to discover what to do with these patients that don't buy completely the treatment plan we're recommending, but doing what I'm telling you to do. And if you're not, you can get it much more thoroughly in early podcasts. They're actually labeled Comprehensive Treatment Planning 1 through 5. Because, as you might remember, there are 5 arenas of their mouth that I review with them. And I tell them that. I walk in and I say, listen, I don't say we're going to do a comprehensive treatment plan. I walk in right away. I'm very laid back. Remember, we've also asked the significant other to come to this visit. And I will tell you, 70% of the time, they're in a dental assisting chair at this point. They were brought back after the x-rays were taken, after the patient was charted. And I walk in and I'll say something very casual like, hey, how did you guys find me? Because I want to know. It makes a difference to me. Was I on some insurance list? Did I treat 3 or 4 or 5 people they know? I've had everything happen that you can imagine. I'm not shy about marketing, and that's a subject for another podcast. But a lot of people have heard about me just that way. Hey, I would like them to think that they Googled me and I got amazing reviews, and sometimes that is the case. But sometimes it's just, I don't know, I was on a list. And, not to confuse you, I do participate in about 4 insurance plans. I've eliminated all the others for myself. And I go back and forth with the 4. I've been out of insurance before, totally. And I've taken it back, and I go back and forth, and there's nothing wrong with that, by the way. You don't have to apologize to anybody for anything you're doing in the beginning. You got to pay your own bills. So you do what it takes, but be mindful of the steps it takes to get to the type of success and blueprint I'm trying to give you, because you'll never get it to it if you just dominate your days, your 40-hour week, your 35-hour week with insurance plans. Obviously, it's going to be a mix. Okay. So I go through and I tell them, I don't tell them they're getting a comprehensive treatment plan. I tell them, listen, the best thing I've ever learned is a concept I've called, that I like to call what to do when. This is a key moment with you and this new patient. So they're in the chair, their spouse is next to them, and you're looking at them and saying, I've learned a lot in this profession. But what I've learned the most is something I call what to do when. And what that means is right now you're sitting in my chair. We met, whatever it is, 20 minutes ago. And I'm going to look at different information in your mouth besides the one thing you came in for, if they came in for one thing. And I'm going to give you recommendations. So the question I have right now is, what to do when means, how do I know what's really the right thing for you? And how do you know it's the right thing? Well, I'm going to tell you what it is. I look at 5 things I'm about to share with you about your mouth. And the 5 are, and I do it slower than this. I'm doing it for the purpose of this podcast right now, just like this. I'll look at the health of your gums and bone. And I'll tell you right now, I'm a stickler about that level of health in your mouth on everyone. And I have good reasons for it, which we'll get to. Number 2, I'm going to look at all your teeth, not just the one you came to me with. And you know why I do that? Because it saves you money and time. If I catch a problem early, if I don't have to cap or crown a tooth, if I don't have to root canal a tooth, and for goodness sakes, if I don't have to have you lose a tooth, you win, and I win. I want the least you can have. Listen, I'm talking to my audience right now. I'm talking to you on my podcast. That is a great thing for you to say to a patient, and mean it, by the way. I want to give you the least invasive treatment plan that will work. So there's certain things I could say to you tonight, maybe after I look at your mouth, that you'll want to hear, but they won't work long term. So I'd rather you do nothing. And I'm not talking about pain. We can always pull a tooth. We don't always have to replace a tooth. But I'm talking about a denture where they need an implant over denture. I'm talking about a tooth that needs a crown where maybe you're going to provide a very large filling. I mean, this, my friends, of anything I've said on all these podcasts, is the moment of truth. You deciding what is okay, given their situation, especially if they won't commit and can't commit, which is very, very often the case, not just in my office, but in a lot of your offices. And we're going to talk about that specifically in this very next podcast. I'm sorry it took so long to get to this, but it's critical for me to lead up to this so that you know how to roll right from there. Because here's the thing. If you give them what I just said, and I didn't finish the other 3. I said gums and their gum health, all their teeth, not just the one that they came to you with. They're missing teeth, and does that factor in any way negatively to their treatment plan? 4, their occlusion, which I'll tell them, we're also going to look at how your teeth come together and see if that has anything to do with why you're here today. And then the last thing I look at is aesthetics. Now, naturally, and I'm talking to my audience right now, if they came to you for an aesthetic consult, well, then that's a different story. You can get to that a little quicker, but you still have to look at the other 4 factors, right? I mean, you're going to restore 7 through 10. If they have multiple missing teeth everywhere else and they have a collapsed vertical dimension of occlusion, and the balance of forces will never be achieved if you don't replace teeth. Now, I mean, a lot goes into that, and a lot of experience goes into that equation. So listen, this was setting you up for the very next podcast, which you're going to get next week. If you have any questions, please send them to me. You know I like to send you stuff through the email. It's free. My course isn't free in my office, but the stuff I send you when you ask me to send it is indeed at no cost, of course. So thanks again for listening to the Lionhearted, and I'll see you next week. And we'll continue this subject. Thanks. See you then.